Good evening, everyone. I won't take up much of your time. I'm Dr. Isha P. I'm the consultant transfusion medicine at High-Tech City. Very briefly about what is plasma exchange and what all cases we have done, most important cases at least. TPE denotes the selective removal of patient's plasma which has the pathologic substance and replacement with crystalloids and colloids. So what is the rationale behind TPE or PLEX? Either to remove the autoantibody, to deal with hyperviscosity, to remove the immune complexes, low density lipoproteins, or in case of TTP where we correct the deficiency of the plasma factor. So exchange volume, this is important because once we initiate PLEX, we think, oh, the more volume we process, the better it is for the patient, but that is not the case. There's something called exponential decay. So one total plasma volume will cause a reduction of 35% of initial value of the offending substance, whereas second TPV will only reduce the offending substance by a further 15%. So we usually limit ourselves to 1 to 1.5 times plasma exchange. So the most common molecule targeted is IgG molecule. As you know, it is 50% in extravascular space and 50% in intravascular space. So 1 to 1.5 times TPV when we process, we are removing about 60 to 75% of the intravascular material. But there will be an obvious rebound phenomenon over the next 2 days. So 80 to 90% of the reduction of IgG can be obtained with 4 to 6 exchanges in 14 days. So since we are removing a large amount of plasma, either when we choose albumin replacement or FFP replacement, there are going to be some biochemical changes. So there will be a 30% reduction in platelets, which will get back to normal within 72 hours. Your proteins and individual coagulation factors will all decrease, but it's all transient. It will come back to normal in 24 hours. Fibrinogen alone will take 72 hours. Electrolyte imbalance is very minimal. So there's something called ASFA classification. Why I have put this slide is because every case we take up for PLEX, at least here we are going to follow the ASFA guidelines where they have divided the disorders into 4 categories. Category 1 is where PLEX is identified as the first line therapy. 2 is where we can use PLEX as a secondary line of treatment or in conjunction with other modes of treatment. 3 is where only case reports or case series have been reported, so decision making should be individualized and it is based on the clinician. 4 is where there are certain disorders where you should not do plasma exchange. So I will not go into these slides in detail. Coming to case 1, we had a 12-year-old boy who presented with complaints of vomiting, easy fatigability and oliguria. The lab parameters showed features of anemia and signs of hemolysis and peripheral smear. There were deranged RFTs and elevated LDH levels. The renal biopsy showed TMA with no evidence of necrosis or crescents. The anti-factor H antibody levels were found to be very high, 8,000. The patient was diagnosed to have complement-mediated TMA. So complement-mediated TMA is a category 1 indication as per ASFA. So TP was initiated, 10 procedures were done, immunosuppressive treatment was done, patient went into remission for 4 years. But he returned to us with a relapse of atypical HUS. Again, we noted signs of anemia, thrombocytopenia, hemolysis. So we started conventional TPE. When I talk about TPE here, all the cases, I mean centrifugal plasma exchange. So conventional TPE, we did 64 procedures over 18 months. Each cycle involved 8 procedures of TPE. This was done on OP basis. So every time the patient would come, we would do plasma exchange on alternate days for 8 times. And then he would go back, come back within 1.5 months. We noticed a 52% reduction in the anti-factor H levels following a cycle of TPE. Remission was not achieved after 64 procedures of plasma exchange. So after further discussion with the nephrology team, we have initiated something called cascade plasma pharesis. So we did only total of 8 cascade plasma pharesis over 1 year. Patient finally went into remission. So what we have done here is, we have connected this cascade filter to the centrifugal machine. So it is essentially double plasma pharesis. So after you do the centrifugal method, the plasma just passes through the cascade filter. We are not going to remove anything, and the plasma, filtered plasma, goes back to the patient. So you are not replacing plasma also. So after single procedure of cascade plasma pharesis, we noticed a 73% decrement of anti-factor H levels. So this graph you can see, after 8 procedures of conventional TPE, there was only reduction of 52%, whereas within one single procedure of cascade plasma pharesis, there was a reduction of 73% in the anti-factor H levels. So an international consensus approach to the management of atypical HUS in children suggested eculizumab is the first line of treatment. If it's not available, you start plasma exchange. If plasma exchange is not available, you at least start with plasma infusion. The right article is from PJ Chandigarh. They analyzed 30 pediatric cases where they did 169 therapeutic plasma exchange procedures. Each patient underwent minimum of 3 procedures. They concluded TP is a safe and effective modality in pediatric atypical HUS. So as next case, a 67-year-old male presented with difficulty in walking and standing for 10 days. He had history of difficulty in getting up from sitting posture, history of difficulty in gripping objects, also from the last 1 week. There was no significant medical history. There was hypotonia in lower limbs. The tone in upper limbs is normal. You can see that the deep tendon reflexes are diminished. Sensory system is also affected. The nerve conduction study revealed bilateral severe sensory motor polyradiculoneuropathy. CSF analysis showed raised protein with no cells. So this was a case of AIDP which was referred. AIDP is again a category 1 indication for ASFA guidelines. So this is the calculation we have used. We have used standard volume plasma exchange. So 1.2 TPV was processed for each cycle. We have done 5 cycles on alternating days. Patient subsequently improved. With physiotherapy, he was discharged. So the article on the left is from AFMC, where they have analyzed retrospectively 57 GBS cases, where they have done plasma exchange. Minimum of 3 to 4 plasma exchange per patient was done, or until the patient improved. Not necessarily every patient has to undergo 5 cycles. So they found TPE to be an effective mode of treatment for GBS. The study on the right is also a study from Turkey which analyzed 56 patients with GBS over 7.5 years, also at the same conclusion. So coming to the next case, a 56-year-old male presented with complaints of burning micturition, increased frequency of urination, and lower abdominal pain. Patient also had history of fever and vomiting with the loss of appetite. So the investigation showed thrombocytopenia. Peripheral smear, you can see here there are histiocytes, there's NRBC, there's polychromatophils, all signs of hemolysis basically. So there's elevated creatinine and raised LDH levels. So we have done the ADAM-TS 13-factor activity. If you had listened to Dr. Ganesh lecture, this patient initially had, there were signs of MAHA and thrombocytopenia. We have started with PLEX. We did not wait for the ADAM-TS 13-factor activity. This was initially being done by our department, so it is done. On day 1, it is 1.2%. You can see the improvement. Day 19, it is 9.6%. So ADAM-TS 13-factor activity, if it is normal, it should be above 10%. Why we have done ADAM-TS 13 inhibitor levels? We should do that because if inhibitor levels are more than 10%, it shows us that it is acquired TTP. So TTP is again category 1 indication, and we have done 6 cycles, continuous, consecutive cycles. Okay. On the left is a retrospective multi-center study where they analyzed 163 patients with TTP for 5 years from 10 centers in Turkey. TP is found to be extremely effective for both primary and secondary TTP. The article on the right is from Mayo Clinic, where they claim, after analysis of case series and various case reports, that coming to TMAs other than TPE, like complement mediated or HSCT associated or HELP syndrome associated or malignancy associated, essentially TPE is going to be helpful, but they also claimed RCTs are lacking. So we had a 46-year-old male who's a known case of alcoholic hepatitis, presented with abdominal distension, jaundice, swelling of feet for the last 20 days. On examination, icterus pedal edema was positive. In view of worsening creatinine and urine output, patient underwent 2 cycles of SLED. Patient had fever and antibiotics were escalated. In view of persistent hyperbilirubinemia and coagulopathy, TPE was performed on 3 consecutive days. So acute liver failure is again a category 1 indication as per ASFA. You can see the calculation. We have not done high volume exchange for this patient. We have done a standard volume. Standard volume is what we call 1 to 1.2 TPV standard volume. We have just done that. And you can see the trend in bilirubin levels. 3 consecutive procedures were done and bilirubin just normalized. So there are various studies regarding how much volume of plasma exchange should be done in alcoholic hepatitis. We'll see the right one first. That is the earliest study published by Larson et al. Across Europe. It is a very big open label RCT which suggests, I think it enrolled 192 patients. They showed improved outcome in patients who underwent high volume plasma exchange. When they're talking high volume, they're talking about 8 to 12 liters plasma exchange. Coming to the one on left, this is the Vellore protocol, where they showed low volume plasma exchange and low dose steroid improve survival in patients with alcohol related acute and chronic liver failure. When they say low dose, Vellore protocol only means 50% of total plasma volume they are doing the procedure. The most recent study published shows standard volume plasma exchange improves the outcomes. This is again an open label RCT. This is published by ILBS Delhi. They said 42 patients were enrolled for this. A lower volume strategy of plasma exchange could effectively improve outcomes by ameliorating the systemic inflammation, improves the microcirculation and reducing the cerebral edema. So final case of the day, a 26-year-old antenatal mother, G2P1L1, 36 weeks period of gestation, underwent emergency cesarean section in view of preeclampsia and HELP syndrome. On POD1, patient developed sudden onset of breathlessness along with decreased urine output. Peripheral smear again showed signs of microangiopathic hemolytic anemia. You can see spirocytes and schistocytes on this picture. Patient had high blood pressure. TMA was diagnosed on POD4. So this is a category 3 indication. So you remember what is category 3? Category 3 is where the decision is individualized based on the treating physician. This was done after consultation with the critical care team. So this was the first case which started off a series of cases where all PPTMAs were treated with plasma exchange. 6 sessions were done with 1.3 times plasma volume exchange. So you can see the drop in LDH levels and increase in platelet count. So from day 5 to day 10 of post-operative day, we have done plasma exchange. You can also see improvement in hemoglobin levels, hematocrit levels, the platelet levels. LDH also improved, urine and creatinine also improved over the course of treatment. Patient recovered following the treatment. Duration of stay in the hospital was 26 days. Again, this is a report from International Working Group supporting the use of plasma exchange in postpartum TMA. Thank you.